All right, thank you for joining us today. We're glad you're here. We're here about an important topic, healthcare reform. Certainly on the news agendas of just about everybody these days. And as you well know, I'm sure, the House and the Senate both have bills that are coming out, emerging, and the conference committees have yet to convene, but undoubtedly the President is behind something, so we are rather sure that something will come. And we're so glad to have experts today who can help us to understand this array of issues that are before us, and there are far more issues than we will be able to cover in this event, but nonetheless, let me just put this here for people coming in, grab one there. Our guest on the left here is Dr. Dick Elliott. Dr. Dick Elliott is at the Mercer Medical School, where he's, among other things, director of the medical ethics program at the medical school. And also, you are a professor of what?
Internal medicine.
Internal medicine, that's what I thought, but I didn't want to make a mistake. Very good. And thank you for being with us today. And Professor Bill Hervey is next in line. Professor Hervey teaches at Macon State in Health Services Administration. Why don't we go so people can feel free to come in, leave at least one of them. And he also is an adjunct professor, teaches health law here at Mercer Law School. And Bill, thank you for joining us as well. Carol Babcock is next. She's the manager of palliative care at the Medical Center of Central Georgia, and has some real on-the-ground experience of dealing with end-of-life issues, and we're glad that she's with us as well. And her boss is with us, Don Faulk. He is the CEO of the Medical Center of Central Georgia, and he knows about all these issues and lives them on a constant basis, and very knowledgeable. We're very thankful that he's with us today to share his knowledge about these things. We have an agenda of a variety of different questions, and we're also open to your questions as well from the floor. If we'd like you to, as you go along, if we could distribute these, Professor Griffin here actually organized this panel and just asked me to moderate it, but it's really his baby. We thank you, Warren, for coming up with this idea and putting us together. And what we'd like to do is pass out for you some index cards so that you can get your questions down here and to the panel, so we can try to do that in as efficient way as possible. And you might, listen to what you're hearing and jot down your own questions, or if you wish to intervene and raise your hand and so on, to make it current to what somebody's saying, feel free to do that as well. And so with no further ado, let's go into our first topic question, and that's really sort of the big picture question about what is the governmental role in medical care, and is there a right to medical care? It's an idea that has been around for a long time. FDR, in his 1944 State of the Union address, indicated that he thought there was a right to adequate medical care, as he put it. Adequate, didn't say superlative or extraordinary or something, but he said adequate medical care, and the right to an opportunity to have good health and to enjoy a good quality of life. And I'm interested about our panelists. What do you think is there an expectation, a reasonable expectation of a right to adequate medical care for an American, and if so, what is the government's role in it?
Well, I'll speak up first.
Sure, Carol.
And some of my background, just so you know, also I've worked with Department of Family and Children's Services and Central State and Home Health Agencies, so I've seen a lot of patients that, to me, pretty much fall through the cracks. I personally feel that everybody has a right to adequate health care. I don't know exactly how you define that, but speaking from someone who has a chronic disease myself, when you deal with pain and issues like that, from mine is arthritis, but I get up and go to work every day, and I'm able to do that because I have adequate health care. Of course, I'm in a job where I have health care coverage, and that helps me to be able to afford what I need to be able to do that. I have also run into a lot of the managed care issues because of having a chronic disease, that a lot of people don't understand that we, first of all, Medicare and Medicaid is a government-run health care program. So we already do have government-run programs here. Also, our private insurances, most of them now are managed care. So our doctors are not always in control of what simple things they can do, such as, for me, going to get certain type of medications for arthritis. You had to go through each level of medication to prove that you needed the next one. Instead of when your doctor says, well, I know what kind of arthritis you have, and the most appropriate thing is for you to jump straight to this level, your insurance company will not allow that. So, you know, we're all very mistaken if we don't think we already have some government-run programs already out there.
But to follow up, do you think that the government has an obligation to ensure that people who are not now covered receive that coverage? Because apparently there are some number of millions of people in the country that are not covered by medical insurance. Does that mean they're not getting care in your perspective? I mean, you've dealt with a poor population.
I always like to involve other people. I feel like there may be some misconception about who is uninsured. I mean, those kind of people who are, of course I work, so I have insurance, and yes, I can say, well, why should I pay for other people's who don't? I think the government has to step in because we don't always have things, we have to have rules to go by. We, unfortunately, as human nature, we work toward making money. Our pharmaceutical companies, our insurance companies are there, they're trying to make money. And so it's very easy for them to turn down people who already have a pre-existing issue. If I were to lose my job, if Mr. Faulk here said you no longer have a job tomorrow, then it would be very hard for me to find insurance even if I wanted to be an insured person. So I think that the government does have to have some rules that are just basic rules that people have to go by.
Bill and Dick, do you have thoughts?
Well, legally, there's a couple of rights to medical care. I don't think that's what we're talking about. But legally, just to recognize that, since most of you are law students, under Olmstead, there's a right for the mentally disabled to have access to community services. Supreme Court, 1999. And of course, in jails and prisons, there's a right to such care to be free from neglect that would constitute deliberate indifference under the 8th Amendment. But I don't think we're talking about legal right there, because I don't think anybody said there's a legal right in other settings, at least I'm not aware of it. But morally, I think there's a right, because the question comes up, how do you exercise your other recognized rights if you're in poor health? If you don't have a right to adequate care, how do you exercise your other rights? So my answer is yes.
And taking it one step further, the quote is a basic right. It's not a statutory right. We're not talking about a legal right here. We're taking it up a notch. It's one of those fundamental rights that we get from being human beings, if that's not redundant. And so looking at it that way, it's hard not to have the belief that healthcare is one of those things. Now, that said, we live in a world of finite boundaries. How we deliver it, outside of this aspirational moral rights, okay, we all agree, now how are we going to do it? And that's where the rubber hits the road. And that's where the legal stuff does come in, because those are the rules that we play by.
You know, we do have, at one level there is a right, because if you have no insurance and you show up at the emergency room, we absolutely, without question, have to go through a basic examination. That is law. We can get in deep trouble if that does not take place. So there is an established right, at least at that level. That is probably, and I guess in this whole debate, the issue of access is to some rational system of care. That is not necessarily a system of care to wait until something breaks and goes in the emergency room. So I think that's the point at which the right, is there a better way to provide access? And I think is a part of, that's one of the fundamental things that everybody keeps talking about. Better access, lower cost, and those are the two premises. And I think the access point, there has to be a better way than the emergency room, when things go bad.
And even in the emergency room, it's not for treatment of ordinary medical conditions. It's only for, the requirement is to screen for emergency medical conditions and to stabilize those emergency medical conditions. Once they've determined it's not an emergency medical condition, but some sort of ordinary non-emergent condition, there is no right to further care.
And going back to what Don says, the first time I've ever heard the word rational and Impala used in the same
Yeah,
sentence.
I didn't,
But it's an example of trying to give access to people using the powers that law brings and trying to do the right thing, and then all of a sudden realizing it, it just manifests itself out. The EMTALA program, as we was talking about, it's not only diagnosis, it's stabilization. And it's childbirth, and stabilization for childbirth is delivery of the child and the well-being of the child. So it goes beyond just saying, okay, you're sick, go home. One of the ways hospitals have protected themselves from losing Medicare and Medicaid, which is the teeth behind EMTALA, is they will, instead of telling someone you don't have an emergency, what they'll do is they'll just give them the pills, give them whatever it takes to get them out of there as defensive medicine. So what perfunctory happens is the emergency room, the #1 place in the world for emergency or healthcare, now becomes your primary care facility of last resort. And that's an access rule that creates that.
And we're already tinkering with the legal system through the payment system
Oh yeah, the payment
to create
system.
this kind of odd situation. So it's kind of a moot question. We're already involved legally, I hear you saying. And
Oh, you're down
what we
the
need
road.
to do is fix this in some way so that there's a better, more rational system.
Sure.
Let's hear about the public option. That's one of the contentious issues in the last few weeks about possible healthcare reform. Would a public option be a reasonable answer to some of these access and cost concerns?
I'll jump in.
Sure.
I've been waiting for that.
Yeah. To cover the uninsured, the public option, that one has become a lightning rod. Just that word itself is, and which is a lot of this debate going on nationally. There's a lot of, lightning bolts striking from all over without, perhaps a real target or whatever. It's more D versus R, but that's a whole other topic. I think the public option, it depends on who can have access to it, at what rates they pay, and at what rate an individual would pay to get in it, and at what rate that plan itself, presumably run by some governmental whatever, would pay the providers. And is that a negotiated rate, or is it Medicare rates, or whatever? Because that really is the key for a provider like us. And right now, in the aggregate, for governmental programs, I won't just say we, hospitals across the country lose money on both of those categories of care. There's a huge cost shift going on. I've got part of my little presentation that I give sometimes. The cost shift, anybody who has insurance is paying the freight for the shortfalls of Medicare, Medicaid, and the uninsured. And so it's a cost shift.
What's the aggregate cost shift, say, in a hospital like yours? What percent are we talking about?
It's about, if you look in the aggregate, I'm trying to sort of going about numbers from the 08. I've got an 08 chart here, but got some copies of it, got enough. But basically, we lost money on those first three categories to the tune, on cost, not charges, of about $59 million. We charged insured patients their share, plus made 72 on it, so 71, so that we had a $12 million plus for that year, which that particular year is 2% margin. We've obviously got a lot of dollars flowing through. So we do about $600 million a year. Expenses is what it takes us to run the place, so $12 million margin is 2%. And so that's the overcharging of the insured to pay for the shortfalls of the other. And that's the magnitude of it. So if we are talking about a public option that tries to go at that uninsured, for us, 7 or 8% of patients, and pay them instead of at down here, if we pay Medicare, we would still be losing money. We'd have more people covered, still be losing money at that rate, but it'd be better than it is now. The problem comes, do you have a box or a firewall that keeps the insured patients, who we're currently charging more than for their care, can they jump out of that more than and jump into this public option? That's where the problem with the system would come. And that, I've got a little chart that sort of shows, if a third moved over, if 2/3 move over, what's the total economic impact?
And one of the studies I saw recently this past weekend indicated that some folks are anyway estimating that only 2 million people may actually jump into a public option, at least the one that's presently designed. Is that, so in the point of this study apparently was that it would be, we're overstating the significance of the public option.
Depends on what it is, and this would be, and I had one of the local employers here, roofing company, employs 200 or 300, 400 employees, tries to give health insurance for theirs. He said, if there's another option, and if our employees are having to pay, I don't know, pick a number, $1,000 for their premium, and this government option is out there for $600, well, whether they're paying it or whether I'm paying it, guess which choice? In time, there may be a little initial fear, but they're going to look and say, that's Medicare. In fact, I've heard a lot of comments that say, I don't want a government option, I like my Medicare. Well, so, once they figure out it's sort of like Medicare in terms of the benefits, then I think that it would be more than what's being talked about.
Yeah, I think if you have the public option and it meets the needs, what people expect in healthcare, it's got to be attractive enough to start getting people to jump in. And so it's going to become a one-sided system. It's maybe the tragedies of the commons will come in, but I don't see a political system, and it's going to be a politically controlled system. We see that now with state Medicare, Medicaid. That's not going to be attractive to people. So with that said, yeah, and you tie to that the ability of those running the public option to use their tax and spend codes and to use regulations. And I think what you have is the ability to make that into a single-payer system in the long haul. I don't know if that's bad, but those two together really have a hard time.
So you're talking about the phenomenon of crowding out. That
Sure.
When a government gets into something, it tends to crowd out private competition. It's been a
Yeah.
long understanding that in other markets.
If we're not careful. I don't want to say it's going to happen all the time, and hopefully it won't, but boy, you open that up.
There's many examples where government and private coexist very happily. Education is one of them, as we see here. Our public universities and private universities have lived together for many years. There's a lot of other examples of where we live together, too. Part of what we have to keep in mind is this will be an experiment. I think it's a badly designed one. The poorly designed part of this is they're suggesting the public option, the rates will be negotiated. The point of this, to me, should be cost containment. Because our ability to provide universal coverage, to provide more preventive care, to do these other things we'd like to do depends on our ability to contain costs. And as soon as we take the government out of the setting the rate part, and we say, well, let's go to some sort of market-driven value here, a negotiated rate, the predictions are that we're not going to save any money. And it's unclear to me that we're going to be able to achieve our other goals with this if we don't have more cost containment. So I think we're missing the boat here. This looks like one of those compromises that really we'll be able to say there's a public option in here, but it's really not going to serve its purpose.
So cost containment is one of the things that's missing from the plan. What else is missing? And
it's the main thing.
It's the main
oh,
thing.
no, I shouldn't say that. I shouldn't say that. CBO on the HR 3962 predicts an overall savings over 10 years to the budget, a reduction in the deficit. So there is some cost containment, not to the extent that I think it makes us competitive globally in our businesses and makes healthcare more affordable and will provide for universal access.
I think that I agree. What's not in there now, and I agree, it's broader than real cost containment efforts. The current system is designed with wrong incentives. I put the little note out that I had sent to our employees about a month ago, and basically, currently, much of the system revolves around quantity, and from the physician's perspective, and it's a fee for service, which in a basic it sounds okay, but there's the opportunity for overutilization, and to get paid on eaches, and physicians who, for many of them, have not had a rate increase in 8 to 10 years. The only way to deal with the inflation that they are seeing in their practice is to do more eaches, and that just drives up utilization. And again, that's a very subjective thing. Do you need an X-ray of every annual physical? Would every other one work? You know, and I'm not a doctor, so I can't get into all of that practice, but the incentives now don't align hospitals, physicians, and other providers into more overt efforts at creating a cost-effective process of care. It's a lot of silos, and there's not much discussion in between, and systems of care, if they could be incentivized, might really bring some fundamental change. And that's where I think a lot of real dollars are. Playing by the current rules, you know, we have to do, I don't know, however many, $300,000 x-rays a year. You know, we're doing those as efficiently as we possibly can take x-rays. Do we need to do 300,000 a year? Maybe 250 is the right number. Maybe some of this defensive medicine's been mentioned drives up some of that number. Really going after what is a good quality care, efficient care, and those can be very much synonymous, will save a lot more money than trimming around the edges.
I want to highlight what Mr. Faulk just said, because there's, I think, an implicit understanding that more care is better care. Most of us believe that. It's absolutely false. In most circumstances, more care is worse, certainly no better. The data that drives this conclusion comes, and it's robust. It's been confirmed over and over that areas with the highest overall utilization, the most expensive care, generally have the worst outcomes. And it's not because the patients are sick. It's not because they're older or sicker or worse lifestyle. It's because of these perverse incentives that Mr. Faulk talks about. That in those areas, you tend to have a higher utilization of specialists. That's more expensive. You have more invasive procedures. That's expensive. And you have worse outcomes, because every time you stick a tube in somebody and do a procedure, you're at risk for an adverse event. And so when you look at the data, which looks at the cost of care versus the quality or overall outcome of care, it's inversely related. And that's paradoxical. And I think that's one of the more profound results around which we ought to be conceptualizing our health care reform.
To respond to that, what could one do in a public program or some kind of a reform agenda?
Well, I think Mr. Faulk again was touching a bit on that. Looking at our incentives, do we just want to incentivize individuals, physicians, to provide more care? Because that's the way it is now. Remember, the most expensive piece of medical equipment is a physician's pen. They're the ones that order the tests. They're the ones that make all this stuff happen. We have to incentivize quality of care across a continuum. So these integrated systems that link hospitals and clinics and diagnostic centers, home health care, are able to look more at outcomes. They're able to integrate their care through electronic health records, so you can track care across the system. You can incentivize a system to provide better care looking at outcomes, and not just incentivize a physician for doing procedures. Right now you can't incentivize quality of care very easily with a physician because they don't do enough, say, of any given procedure to say, yeah, you're better than somebody else. Statistically, there isn't much difference. And plus, the care they deliver depends on all the other people they work with. But if you look at a system and incentivize that system for delivering high quality of care based on measures I think we all agree on, and incentivize it to be, and I hate to use the word cost effective because that's a little controversial, but something like that, I think you're in a much better position than our current system, which really is perverse.
I think the role that government has in that, and this has happened over the last 25 years, whatever Medicare and Medicaid do in terms of payment mechanisms, the insurance, the private insurers adopt that. The DRGs came in 25 years ago where they went from a cost-based reimbursement to paying us by episode of care. Now that's the predominant payment method. So I think if they set up perhaps new ways of paying, encouraging that, get away from fee-for-service, then I think that would be, the insurers would go quickly along as well. I think they will. I think that's government's role in this whole thing. I've been trying to sort of just decide for myself, what is government's role? Government has the unique role of being able to define the boundaries and sort of the rules of the game, and then people can play within that game. You know, who set up for the railroad industry, the gauge of the track, how far the tracks were between each other. They weren't always the same distance. Somebody set that up somewhere along. You know, for banks, the interoperability in computer systems, you know, that allows each of them to talk to each other. That got set up by some coming together at some level to put some standardization. There is an acute lack of that in the healthcare world.
One of the things that you both briefly touched on was defensive medicine and the incentives for defensive medicine. Both these bills, I believe, include some malpractice reform provisions. What's your position on that? Do you think it's desirable? Will it really result in better patient outcomes and less defensive medicine by doctors?
Well, my reading of HR 3962 is that it encourages states, and please correct me if somebody's writing this more carefully, that it encourages states to set up tort reform, liability reform, as long as you don't cap attorney's fees or non-economic damages. So essentially they're looking at one of these models, maybe some sort of administrative tribunals, for example, various sorts of panels that might hear these things, or these, what's these called, these disclosure payment plans where healthcare organizations disclose their errors and offer payment. And actually it turns out that's probably not a bad way of doing it. It's probably ethical. But it's not really the kind of reform I think we would need to go the whole way. But even if we went the whole way, it's unclear that it would save very much percentage-wise. Maybe a couple of percent, 1 to 2%. It's not the 20% you sometimes hear. The flip side of that is, if you compound 1 or 2% over a number of years, the potential for savings out of the federal budget is huge. Hundreds of billions of dollars, a 1 or 2% savings. So even that could be significant. But anyway, that's my understanding. Anybody else have a take on that?
The House bill is talking about, actually I think they used the word mediation panels. And as Dr. Elliott said, if the federal government will give the state a lump sum of money if they establish these panels with the understanding that the state's not allowed to cap attorney or impose attorney fees or any kind of caps on damages. So the problem with that, and I guess it's like a lot of administrative kind of tribunals, is what's the mediator going to be? Which side is he going to? You know, the same problems that come. I don't know if I'd rather have a jury in the Bronx, New York, or a mediator in California, or someone in rural Minnesota. I mean, they're human beings, and you know, so it could be good, it could be bad. Again, responsibility of the system. And I don't know if it's going to save that much.
One of the other technical legal questions, Bill, that you and I have talked about a little bit is some of the jurisdiction stripping aspects of some of the bills. There's talk about trying to exclude from judicial review some of these systemic reforms. What's your take on that?
Well, they're allowed to do it. I mean, you know, one of the things we're talking about here is the ability of the federal Congress to control all the courts in the federal system below the Supreme Court. The district courts, the appellate courts, and their jurisdiction are basically at the will of Congress. They can, only the Supreme Court stands alone. And what they've done in this bill, and they've also done it in so many environmental bills, and we see it in the Immigration Reform Act, is they basically say there will be no administrative or judicial review of decisions under this act. Now, if you want efficiency, there you got it. You know, there's your efficiency. Shut up, go home, we don't care. I don't know if that's the way you want to run your government, but it's there. If your only objective is to cut cost or to cut financial cost, that's a good way of doing it. If you look at cost as not only being money, but being other things in your system, you know, then you may want to have some sort of checks and balances. But it's there.
Let me ask you about another technical aspect of some of the insurance coverage aspects of these provisions, the no rejects rule, the idea that insurers can't reject people for pre-existing conditions. People have criticized that characteristic as creating these incentives for healthy people to avoid getting coverage or high-level coverage until they get sick, and then jumping into a Cadillac-type program, not having paid for it right up until the time they were sick. And is there a way to solve for that kind of a problem? Is it a basic flaw in these proposals? What's your take on that?
I guess I'm an advocate, obviously, of everybody having coverage. And I know even when you say everybody should have coverage, as in Massachusetts, it's still 2 or 3% that don't. But, you know, access by all paid by all is the best way to spread that risk around and to be most fair, I think. And otherwise, you know, as the situation you described, you know, the bulletproof people who are a lot younger than me, the bulletproof 25 and 30-year-olds, a lot of you folks out here, that really, you know, the chances of your using a lot of health services, barring driving too fast and drinking and all those things that behaviorally Americans foster upon ourselves, you know, you don't have great chances of incurring stuff like us baby boomers who the parts begin to break down on. So it makes sense to sort of hang out there. You know, if you are in that wreck, you're going to get hauled to the level 1 trauma center down the street here, and things are going to be taken care of, and you'll be out and whatever. So, but yet, you know, there are some awfully productive and increasingly economically productive years from age just 25 as you become employed and your early career on up into your 50s. You know, that's a point at which if we are to ever have a chance at having a reasonably priced insurance vehicle, everybody has to sort of spread that risk along the way, and if it's going to work out. So, you know, I think it's a fundamental flaw if it does not, at least from the get-go, try to get the coverage as broad as it can and level it out. Because, you know, if you heap it on those people who are most likely to use it, which is us elderly, plus the people who have chronic conditions, who you know they've got something when you say, you know, that becomes, people can't afford that. And therefore that's a lot of the genesis of the problem we have now.
The other thing is, you know, we do that with dental now. It's November. I have on my floor in my office, if I can find it, a file of my latest healthcare benefits. And this year I can go to the cafeteria plan and sign up for dental. So I look at my wife, I look at me, and I say, am I going to need dental work this year? And my wife says, yeah, I need to get this done. Well, this year I get it. Next year, we have that done. I don't need to get that. So I'm jumping in and out of the system using the risk cost disbursement strategy, you know, free ride, not free riding, but using you to subsidize me for that year, and then next year, the heck with you. So I can game the system. So you got to put in ways of keeping people from jumping in and out. We do that now. We do that now with Medicare Part B, which you have to pay a premium for. And if you are eligible for Medicare Part B and then leave, to get back in, they hit you with a higher fee or a higher premium for the rest of your life. It's sort of saying, you can leave, but when you come back, you can't game us. We're going to hit you for more money. You know? And that's maybe something like that, to just change those incentives to keep people from gaming the system.
Should the government be involved in deciding whether to have community rates or personal rates? And by this I'm talking about the notion that community rates are the rates that where the relatively healthy person is in some way subsidizing the relatively unhealthy person versus some kinds of insurance concepts would say that this healthy group of people, they don't have to pay very much, and it creates incentives for people to conduct themselves in healthy manners. What's the government's role in setting that game up? Should they weigh in on either community rates or personal rates?
Just off the cuff, I'd say, you know, the government, I think there needs to be community rating, because again, there's no way that if you've got somebody who has chronic whatever, no matter what age they are, that they're going to have a premium that's going to be affordable, because that's just a known risk. You know, once having done the community rating, should there be individual incentives? Absolutely. We are the fattest country in America. We're the fastest, in the world, fastest driving, shoot more bullets, use more knives. The behavior, the self-destructive behavior in America is a big piece of what the cost is all about.
So you don't say it's not either or for you. You think that you can generally have community rates, at least at a broad level, and then incent people separately.
Yeah, I agree. And I think whenever you're going to get in, we talked before about public options and the effect. Government wants to drive towards community rates. If I'm in the health insurance business privately, I want experience ratings because that's where I make my money. Private business makes their money by doing things differently and better. Government makes its money by pushing, or survives by, and especially ours, by pushing people into a commonality. So community ratings, good idea, but you got to prevent the free rider problem, and with incentives to stay healthy. We do a lousy job in this country of wellness. We're the best medical country in the world, quality. Wellness, we don't do.
Tyler Cohen is an economist at George Mason University. He's been gotten a lot of press recently for saying that the plan that's out there is really counterproductive for the interests of the poor. That the poor will be disincented to extricate themselves from the government dole, basically, and by adding yet another benefit at the low levels of the economy. And what's the answer to that? Is there one? How do you deal with that?
What are the alternatives? If you think healthcare is important, what are the alternatives? That's kind of what we're talking about. Is how do you provide for this healthcare? And I think I've seen something like him, and I was stuck with that. How do you provide for the poor and at the same time address this? To me, it's not really an argument. I guess I don't understand the argument. How do you provide for the poor without labeling it as giving them some sort of reason to stay poor? Maybe I've trivialized the argument, but...
No, you know, you do see that, though. I mean, maybe not in healthcare as much. A great economist told me, sitting in the back, you know, why would you... You know, it's not that much of a question in healthcare because you don't make those spending decisions with your healthcare money. You make your spending decisions with your food stamps, with everything else. But there are people who know that if I go and get a second job, I lose all of that. It's the working poor. So again, yeah, it's a real problem. But there are no other alternatives. I don't know. It's
well,
just sitting there.
One proposal that's been out there, sort of, it sounds like a crazy proposal, but it's using these health savings accounts and making insurance apply only to catastrophic health care costs. So $50,000 or something like that. You pay for everything else, just like dental, pretty much.
Well, just like
you get your
car.
$1,000, just like a car. That's right.
I buy a brand new car. I buy it. I buy what, $5,000 or the first $1,000 in case I run into a tree and destroy the car. But I don't pay for windshield wipers. I don't pay for new tires through insurance. That's just putting more transaction costs. It's just feeding the system. Perhaps what you're saying is we do it like that. The problem is, now you were talking about people who can't afford wellness. We're talking about people who can't afford to bring their kids to the $60 appointment at the doctor. So we just shuffle the problem down. It may eliminate some of these guys in here who aren't getting health insurance for that, but it's not going to eliminate those.
Well, and
Poorest of the poor.
Yeah, and it presupposes a competitive economic market. One of the funny things about medicine is it's not a competitive economic market. It's not a market like Best Buy and other dealers of electronic devices. You have more people selling these things and they compete with each other and they drive the prices down. Medicine is just the opposite. The more providers you have in a community, generally, the more technology they're going to buy, the more they're going to tell you, oh, you can walk out of here without that heart MRI today, but I can't tell you what's going to happen when you hit the sidewalk. What are you going to do? Doctors tell you, you got to have these things. You go ahead and have them. You're not really an informed consumer in most of this. It's not like buying a DVD.
You're not even a consumer. Up until recently, there's been a separation between, in this country, the way the system has traditionally been, is you as the patient are not the consumer. The person making the decision as to what you get, what hospital you would go, that was a great quality system, was the physician. And you listen. And then what would happen is your employer, or if you're in a government system, would pay the physician. And I'm sitting there as a patient, making my decisions based upon what my physician says, or which hospital is closer to my kid's work. The other thing that happens is the doctor doesn't make his decision on costs, because under the old fee-for-service system, they pretty much just passed it along and the insurance companies would pay for it. It was more quality. It was more covering my rear end. Why do the sixth x-ray? Well, I'll tell you why. Because if I do 5, I'm going to maybe miss 1 in 1,000, and that's a potential lawsuit. And nobody's complaining to me for doing the 6th x-ray because the insurance company's paying for it. The consumer, the patient, is happy because they're getting all the x-rays. And pretty soon you're competing on quality and not price. And in this country, 2 hospitals on a corner had higher costs than 1 hospital on the corner. And those incentives get skewed. Today, that's why we moved to managed care, we moved to capitation. And so, you got to get those incentives back.
And another reason it's not competitive, and it leads to a paradoxical market when it comes to healthcare, is you don't know the price of what it is you're going to do then. If somebody says, you need that heart MRI, and you're thinking, I don't know, that's $1,500, or you ask what the price is, most of the time you won't be told. But let's say somebody tells you it's $1,500, you say, I don't know, that's a lot of money. You think that radiologist is going to tell you what? getting a heart MRI, I'll throw in a foot x-ray if that's bothering you for the last 6 months. Well, okay, all right. Hey, this doesn't happen. It's not a competitive market. So that's another reason why costs continue to escalate, is because I think you put it so well that you're not consumers. We're not consumers out there. We don't know the prices. We don't control the rates. We don't know really what it is we need most of the time. So the market is really out of our hands.
Well, and then you run into problems there, though, with people who, you know, are trying to save their money and are trying to be, you know, on top of things, and so they don't get the care they need because they don't want to spend the money.
Right.
And so then they end up with a much worse situation and are in the emergency room having to have care at a higher level.
So the paradox becomes, if I separate the payer from the decision maker or from the consumer, I get irrationality.
Yeah.
And if I put the payer back in the marketplace to make those rational decisions, sometimes rationality is going to hurt them. Which do you want? You know?
Well, and I wonder if some things happened when, because it doesn't seem to me, and I may be wrong, but it became more of an issue when the insurance company dictates who you go to. You don't have a choice of who you want to go to anymore. They send you a list and you have 2 or 3 doctors to choose from. So I can't pick the, you know, I may call around and ask some people who's the best doctor, but that's totally really out of your hands now. Most of that is dictated to you.
Well, it's practically out of hands, but you could write a check and do it. The problem is we don't write checks for healthcare. You know, and that's the way.
John, is there any way that an individual hospital could address this issue outside as a standalone unit to attack it and to try to get the patient and the provider making the decisions on a cost-effective basis? System.
It is so foreign right now. I think and the systems are so complex. We've tried a number of things, not necessarily that particular. As we dealt with rural hospitals, we're the tertiary hospital, highest levels of care, most specialists. We have patients coming from 50 to 100 miles from around. They come in, and we do sort of the highest level of care. Well, the last week of their recovery, they really don't need to be at our place. They could go back to their own place. And when we have been so full for the last several years and on diversion and all that, we can't take patients who really do need that level of care. It'd be rational to see if we could ship them back to their home county and even some of the small county hospitals around here. Reimburse, so we said, well, that should be something to do. We got into more confusing mess, particularly with government programs, of who gets the DRG payment. There's a payment for whatever it is that you got. Who gets it? Now, how do you can't subcontract it out, and that's fraud, and it becomes a bizarre entanglement of regulations that makes everybody just sort of give up. And the physicians, we're having a hard time getting them engaged because, again, as I mentioned, many of them have not had rate increases on their per eaches in 10 years, more or less, and that's a constant fight at the federal level from the government payers. So to get those folks who are trying to do more just to stay where they are and pay the bills, whatever, the collaboration takes time, and I mean, creating systems, and it is that's where I think the role of government or a larger group to be able to sort of change the rules a bit comes into play.
Now, one of the things you mentioned, the rural healthcare issue, and that is one here, our audience is familiar with this issue. This is an important one. In Middle Georgia, we do have many of these regional and rural hospitals that are underfunded. They're going out of business. Meanwhile, the medical center in Central Georgia is growing. It's still huge and
it's huge.
It's a major juggernaut. And the question is, can these other facilities survive? Is there a way in the system to try to adjust rates to help it? One of the aspects of the House bill is to provide the power to something called the the Institute for Medicine, the Institute of Medicine. They're going to be this entity that will go about deciding on issues of quality and value. And they're going to try to adjust prices and essentially to try to juice more money to the rural hospitals and I guess cut back on some services at in the urban hospitals, at least in some settings.
Yeah.
and if Congress doesn't act by May 2012, then those changes will take effect if this institute's going to recommend.
Yeah.
So is that the kind of thing that you
That
recommend?
scares me to death because, and we have worked particularly in the surrounding counties. Obviously, we're a large regional hospital, but we are the Critical Access Referral Hospital, which is a government program that enables very small hospitals to get an increased reimbursement to get the old cost base, whatever it costs to keep them open, not necessarily what they can make. For Peach County, Monroe County, and Putnam County, or the smaller ones around it, we have a relationship with them. We've been trying to work with them for years. The challenge they have is the same challenge hospitals as large as ours, Grady. I mean, I've talked to the media, it's the same. If I know 4 numbers, I can sort of tell how you're doing financially. I know the percentage Medicare, percentage Medicaid, percentage uninsured, and the percentage insured. For rural hospitals, the percentage uninsured and Medicaid proportionately is significantly higher. Medicare is a high number, insured is a pretty low number. That's been one of the changes that has taken place. The other change has been the inpatient to outpatient migration. The things that you used to be able to be admitted into a hospital for observation, and many rural hospitals sort of lived on that, you can't get in a hospital now. So therefore, their patient base, especially for insured patients, has been whisked away into an outpatient setting. So therefore, their basis of being able to shift the cost and stay alive is going away. There needs to be, I think, and we've sort of struggled to figure out exactly how to do this, a redefinition of what hospitals are. To be in a hospital now, it takes lots of specialists and that high-level procedural care and those most sick patients. For many of these rural hospitals in Peach, and I've been to Peach, Monroe, and Putnam, and been in them, most of those were created from Hill-Burton funds way back in the 50s and 60s. They are trying to run, and this is nothing against them, a 50s, 60s, and 70s model in the year 2010. And that model has changed by this migration of inpatient to outpatient. I mean, we've even seen, we may wind up being a 600-bed ICU before it's all over, and with the rest of it being done on an outpatient basis. As we dealt with Peach County specifically, we talked about what a new model might look like. What do they need? And we talked about, and some of the residents said, well, we can't close the hospital, we can't change it. It saved my mother's life. Well, tell me about that. Well, she had a heart attack, and just brought her in, and people took care of her. I said, okay, keep telling me, what happened to that patient? Well, they took care of her, they stabilized her. What happened then? They shipped her up to Macon, she had a heart, blah, blah, blah. So that is the real care that's needed. You need an absolutely good emergency medical service, a good emergency room. You need primary care access so those 12,000, 15,000 residents down there can get the daily services. You need little ambulatory surgery things that, stitch up here and a little procedure. That's, I think, the care that exists and should exist in 2010 with the bedded inpatient migrating to, to larger settings where this is sort of critical mass. I think there is a government role in helping us get there, but it's, again, structuring the incentives to get us out of the old mindset.
If I understand you right, you're saying we don't necessarily need all those inpatient hospital beds in rural areas. That's so important. And keep this in mind. Cost containment, if you're talking about 16 to 18% of GDP, and we want to reduce that, and we're not going to reduce it. In the best of all possible worlds, let's say we get down and we reduce it by 50% or 30%. We're never going to get anywhere like that. Anyway, we're going to have to take a lot of money out of the system. Everybody's going to have to give. Doctors are going to have to make less. Hospitals make less. Pharmaceutical companies make less. You're going to have to give up something too. We're going to have to give up something, and that's access. A lot of what we're paying for in our system is easier access. Being able to choose whom we see, have hospitals in rural areas, testing facilities all over the place. That's a lot of money in our system. We're going to have to give some of that up. We're going to be called on to give up a little bit of what we think of as quality health care in order to contribute to this overall cost containment, to do some of the other things that really do improve the quality of health care.
Our generation has a real sense of entitlement. Well, I say our generation, actually younger. I'm probably like right there at the getting old stage. But people come in and they expect to be fixed. And the people like Mr. Faulk is saying in the hospital, or by the time they get to the big hospital, they have multi-organ failures. They have I mean, they have had heart surgeries one after another. I mean, we can do some fabulous things these days to keep people alive. People are living to be, we had a lady today, we were talking about this, 104 years old, and everybody's saying, isn't that awesome? I would love to live to be that age. But from my experience, I've run into people who are 90 or so saying, it's really a curse because you start losing all these abilities and things, and you don't feel like you're part of society anymore, and you just become a burden to people. Our nursing homes, who I've always assumed that is probably should be the best place to go, where people take care of you if you're dying. Well, they don't know how to take care of a dying person. Does that make sense? I mean, these people in the nursing home, if they start to show any signs of not eating, your basic signs of dying, then they're going to immediately send them to the hospital to be fixed. And the family comes in with them, 20 people, saying, fix mama, I want you to fix her.
Well, a lot of that is if I don't send them to the hospital, I'm going to get sued.
Right. Well, and there's also incentives that are poorly things, but if somebody in a nursing home stops eating, which is a natural part of dying, that's what our bodies do. And I have to tell you, 100% of us in this room will die. That is one statistic we all know. But it is very natural that we stop eating. And the nursing home has a much more incentive to send them to the hospital, get a feeding tube put in, brought back, because then they will get Medicare reimbursement again. And so there's incentives there to do things that are really, is that what the patient wanted? We don't even ask a lot of times. We just assume that that's what they would want. We send them to the hospital to have it done. So there's a lot of misguided things there.
Following up, Carol, with your experience with palliative care, I trust you're seeing lots of situations where there could be huge investments made in dying patients, basically, and that gets into this question that's been a hot button issue recently of death panels and rationing of care. And what's your general take on how to answer the death panel question or the rationing of care question?
Well, I have to say I was excited when I first heard the bill that Dr. Meyer, who is probably the biggest palliative guru, had been a part in Washington and had made some excellent suggestions. And some of those were to give incentives to physicians to start having discussions with all patients. There was nothing in there that said, okay, bring the 80-year-old grandma in there and tell her it's time to die. Nobody said anything like that. But that's the politics of everything got thrown way out of proportion. Some of what is done in palliative medicine is providing people choices. We do have the right as individuals to decide whether we want treatment or not. And to me, that's a right that we deserve. I don't want to be forced to have treatment if my body is falling apart. And, you know, I think that that's the thing that we really need to realize, that these new programs coming in to help us as Americans understand that it is a normal part of living to come to an end. And as we just naturally, for some reason, all think we're going to live forever. And so when it starts to show, we start showing signs that we're dying, then we all feel like we've got to do something to fix that. And I think that there's a lot of things that were brought up that got, as I said, thrown out of proportion, that would give doctors, they're not paid to have discussions with their patients. So, I mean, part of that goes back to, you know, why do you go into a doctor's office and you get an antibiotic and you get all of these things? Unfortunately, as a culture, we expect it, first of all. And if you go to a hospital and you get admitted and the doctor then says, well, really we found nothing and send you home, then you're going to have to pay that bill out of pocket. I mean, there's a lot of things there that we have to fix without going ahead and addressing what are the issues. Like I said, people have multi-organ failures, and we're still putting all of these machines. We have a dialysis center on every corner, which is truly life support. It's a good thing for people who are young and able to get out and really enjoy life. But a lot of people don't realize that they also have a choice on that too, and they may not want dialysis. They may not want a ventilator. And so I think that some of the things that is necessary is to have discussions and help people to be educated about what's going on with their body and help them to make these more informed decisions rather than, you know, with my grandparents, the doctor came to one of my mother and said, you know, we've got to make the decision, your mother's not eating, so we need for you to tell us if you want to feed him too. And leave her in the room to sit there and think about, well, how's she going to make a decision with no education and no understanding of that? But the doctor doesn't want to step up and say, I recommend this or I don't recommend that, because they're afraid of lawsuits. So, you know, end of life has really become an issue, and hospitals, unfortunately, is where people end up to die.
Well, Carol, didn't you say that in the past doctors weren't compensated for having end-of-life decision discussions?
That's, and my understanding is that if you just sit down to have a discussion about advance directives, I mean, we all have the right to put on paper legally what we want. Well, to me, why do you go to a lawyer to do that? Actually, you've got some medical decisions there that you've got to have some education on. You need to have a good compromise there of legal and medical, and doctors are not reimbursed in any way just to have those kind of discussions.
And that's so key, because part of the overheated rhetoric of this so-called debate in the last few months was this notion of death panels. And there weren't any panels that are constituted, or they would talk about Granny, we're going to stop this character, she's 80 years old, and who wants to live beyond that anyway? No, well, what it was providing a means. It was one of these rational incentives to compensate physicians, or I think other staff too, to have the discussion about advance directives, end-of-life decisions. That's a real cost containment measure. Have that discussion early on. It's humane. Well, what would you like to have done if this and this happens? Would you like to be on a ventilator, a feeding tube? Which of these would you have and which are unacceptable? Have those discussions early, so you don't end up in the situation where you come into the emergency room without any sort of prior discussion. You end up on a ventilator for 4 years, and with very expensive care. That's not helping anybody. That's futile. And so what they were doing was incentivizing something we should be doing, that both is better care and lower cost. That's what it was.
Why is it that we can't count on the medical profession to do that, quite apart from whether there's a DRG for it, but why can't we expect that if you are treating somebody for whatever one of these difficult ailments may be, that you would naturally include in that a discussion of what you're talking about?
Compensation. How are you going to get paid for it? That's a very simple view, but doctors are like anybody else. Some will have those discussions.
I would say yes.
Yes.
Good doctors do.
And for example, I know that Dr. Ackerman, who works with Carol and the Palliative Care Unit, that's part of his general practice. And many physicians do that. But it wasn't being done enough. So too many people were falling through the cracks because there wasn't a way of compensating, and physicians were out doing heart MRIs. So this just said, no, if you do this, we'll pay you for it. And it made a whole lot of sense.
Has that been pulled out of the bill now?
Well, I haven't seen it. I thought it was still in there.
There's a committee that looks at quality research. There's a research committee, I forget the name of it, but it's in there. It's still in there.
Yeah, I think one of it is there's certainly the economic aspect of it, but for most physicians, geriatricians like Dr. Ackerman accepted, they were trained by God save lives, and any loss of life is a failure. And we saw that for years and years and years, particularly, my generation, my God, we're going to put them in there and we're going to save them whether they want to be saved or not. And, so we would wind up with patients in ICU for months and years, and, huge amounts of money, huge toll on the family's economic and emotional resources. I mean, and our nurses and other people, and of course a lot of them are trained sort of the same mode, but a lot of them, and some physicians were saying, what are we doing here, guys? This isn't the time to sort of let nature take its course. It's going to happen. And I'll say that in terms, yes, it's been beneficial for, all the players along the way. It's been beneficial financially. The most beautiful letters that I have gotten have been letters of appreciation to us for having started this palliative care unit, and we were among the first in the state to do that, and they're absolutely, the beauty of going on your own terms and surrounded by loved ones and so forth, as opposed to in an ICU room with everything in the world going bleep, 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 and just chaos or some final big, cardiac arrest or something. It's just a world of difference, and it is the right thing to do. But again, it's a sign of failure under the old, I didn't save that person. But it's also, it takes a lot of time to move a family who may not be ready for that discussion. Loved one laying in the bed may be more than ready. But the family, am I going to be, I've got 2 brothers and a sister, I'm going to bring up the question, is it time for mom to go? Or is that something else? Or that's where the staff, and that's not a 5-minute discussion.
No,
that's where the physician.
Then there's the Aunt Mary syndrome, where the family agrees that it's time for mom to go, but Aunt Mary comes from Iowa.
You haven't been here in 6
if you're
years.
going to. I haven't seen her since the potato salad incident in 1999. And all of a sudden, you'd be damned if you're going to kill her baby sister. And all of a sudden, the lawyer brains come in, and that happens. That's real life. The other thing is, it's societal. Don's talking about doctors thinking differently. Society thought differently. You guys who are young, you don't know, but talking about money and medicine is really a fairly current phenomenon. We watch those TV shows. Next time you're watching Nick and Night, look at some of these 1950s television shows. They got the doctor, he's wearing all white, he's banging on the side of the table of the patient's bed saying, why couldn't we save him? Why couldn't we save him? The guy's 96 years old and was hit by a truck. Seriously, that was the mindset. Doctors were not taught to look at the cost benefit when it comes to life. You get this Kantian notion of life is it. All of a sudden, we're having to make those decisions. And that's where we are, and that's where we're having all of this discussion.
Look, we're at an hour. I want to make it easily possible for anybody to take off, and feel free to do so as you wish. We thank you for attending. But let's open it up for questions and get some more from the floor. And I know there's one right here, Ms. Patel.
Yeah, actually, if anyone has a question on the current topic, because my question is on a topic that you already sort of discussed. So, anyone have a question on the current topic?
Yeah, here's a question.
Would it also be important to give incentives to family to discuss this with their loved ones as well as the doctors? Because I know a lot of people, their concern is that a doctor is going to be paid to convince a loved one that it's time to go when it might not be, and it just seems that it might be a good idea to have loved ones in that discussion as well, as opposed to leaving it up to a doctor and a patient. And I was even thinking that maybe it might be a good idea for even incentives on rates to have that discussion with your family and to have those kind of things written into a living will.
I'll tell you what, I'll give you a tax credit if you sign a living will. Attach your living will to the back of your 1040, and I'll give you a tax credit.
Yeah.
I like it.
No, I think the incentive thing, and don't misunderstand. A lot of times it is the family, as the folks in the clinical know. I'm in a coma. I don't care anymore. You're not coming to me, shaking me, saying you won't die. It's the family that's trying to make those decisions, and everybody else in the hospital trying to do the humane thing. So yeah, you got to somehow get those things to change. You got to find an incentive that's going to make it worthwhile for the family to let mom go. That's tough. I have to be mom, but you know what?
Professor Grant, is that me? No, okay, I'm sorry. You go ahead. Mr. Patel,
Oh, yeah. Okay, so we kind of got there with the tax credit thing. What else? I was going to ask you a question about how we can increase private competition, because we talk about the public option a lot. We have this idea that if you have the public option, then what if everybody moves to it? Then it's not really competition. You're not really competing anymore. So are there ways that, even if we have a public option, that we can increase private competition? Like I hear a lot about, you can only buy interest from your state, or international pharmaceuticals can't sell here, or there's all these taxes on health savings accounts and everything. Why can't we just remove these taxes? Why can't we give a tax credit for healthcare? Just things like that. Why do certain industries get subsidies? Why do employers get subsidies? Why can't a person, if I buy interest for myself, how come my employer gets a subsidy to buy for me, but I can't get a subsidy? Should there be a subsidy at all? These things that come into my mind about how we can deal with it on a private level.
Well, part of the assumption, it's a good question. I think it's one we're all struggling with. Part of the assumption is that this is an economic market, like other economic markets, and that competitions will drive down prices. It doesn't happen in this. And again, there's a lot of reasons for it. One is we don't know the prices of what we're getting. We don't determine what we're getting a lot of times. And then there are these funny little laws that are built in, like the Medicare and Ferguson, which exempts insurance and malpractice insurance companies from antitrust actions. Now that provision I think is removed in HR 3962. Yeah, in the latest version. So there's this idea of competition. It seems like a good idea. It would take a lot of changes actually to make it work. You have to know what you're buying. You have to have some control over. You have to say, well, I don't think I'll get that procedure. I think I'll get this one instead. You have to have the medical knowledge. You have to know the pricing. You have to know the sort of comparative effectiveness studies. That's a lot to ask for most patients. There has to be a lot of trust, which again speaks to the role of government in this.
Yeah, the other thing is you got to change the incentives. You know, compensation or cost, it isn't just money, it's quality. Once you leave one part of the equation, then cost could go up. Where your competition is going to come from, you know, this is off topic, but somewhere right now there's an island in the Caribbean that's going to offer tourist medical care. It's already existing.
They already are.
Labor unions up in the Northeast and Michigan are sending people to Guatemala, Costa Rica, because it's cheaper than to do an operation in Detroit. So you're going to have competition in this world. The question is, do you want competition within your closed system? So you'll always have competition. Somebody's going to try to figure out a way to do it better.
I think one of the components of it, and I'm a fan not so much of the public option, but they talk about the co-op approach. The co-op approach basically would be to take, for all of the industries, I think was mentioned earlier, all of the players involved in healthcare, some are making a financial killing. And so to lower it, there's utilization, there's also the cost of putting the thing together. As it relates to insurance mechanics itself, I think a co-op, a non-profit co-op, not-for-profit co-op, like Blue Cross originally started out back in the 20s and 30s when it was the teachers who came together putting in 50 cents into a pot to cover their costs. At least it took the shareholder component out of it, and I think that is one thing that, that would take out whatever inappropriate profit levels are, and that's a very subjective issue.
That's almost a German system.
And so it's, can you do that? I think that's a potential.
We got a bunch of questions around. Let's hear from some. Mr. Smith, is that you first?
Yeah, I'm sorry. I was just listening to your answers, and I seem to think that there's a problem that y'all see with having competition in the marketplace about. I came in late. I'm sorry. I don't know your name, sir, but we were saying about how there would be a massive change happen to shift to have patients decide what their own care would be. Is there a problem you see with that?
Well, the problem is, Dick Elliott, by the way. The problem is how do patients assess the information they're given? So if they're told that they have such and such a condition, a certain treatment is recommended. Are most of us in a position, even as a physician, am I in a position most of the time to decide, I think I'll have that treatment over that treatment? I don't know the costs of these things. I don't know the comparative outcome literature real well. It depends on who's doing the procedure, what's happening. There's a whole lot of information that I don't have access to, I'm not comfortable with. Much different than buying a DVD. I can go look up online and say, it's got this, this, and this. Yep, that's the one I'm getting. Healthcare is much more complicated than that, and the costs are, most of the time, we don't know what they are. So making those decisions is almost impossible, and that's why it's so hard to have a competitive market.
One example would be if you had to have a total knee operation. The most expensive component of that operation is going to be the device itself. The hospital doesn't control that. That's a physician preference, whichever one he or she feels most comfortable with putting in. And that's so subjective. If you line it up by cost, and which we do sometimes for our physicians, I mean, we try to get it from a universe of 10 down to 3, so at least we can negotiate on volume for those 3 providers to at least get it as low as we can. But there may be, 30-40% difference in the cost of those total needs, and it's strictly up to the choice of the physician to do that. And would a consumer ever be in position to do that? I don't know.
And would they even care? Because under the current insurance system, why would they care? So my company pays this, or they pay this.
Well, and I know just, the way we are, when you have something happen like you need a total knee, you're going to call everybody around and find who has the best results. I mean, somebody that gets up and walks in a week, why would you go to the doctor who may use the lower cost knee that patient, those patients don't get up for 2 months?
Or the higher cost knee that doctor happens to use because he likes the rep.
This question right here.
Actually, I don't have a question, but I just want to make a comment on something that we haven't even really talked about yet, but Dick kind of just briefly mentioned it when he was talking about access. We have a very serious problem with an aging physician population. And we also have a serious problem with the government has not increased the number of residency slots in, 30 years? And I think Georgia is going to be facing a really serious issue with this because of the explosion of our population. That I think a study was done by a healthcare committee here in Georgia that Georgia will have the highest patient ratio per physician by 2025. And with this issue, and also I think the way our government has not really addressed mid-level provider care, how are we going to, increase our access with physicians just leaving the marketplace and retiring, and the issues with our midwives?
And the question there, that's another key issue. The question there involves not only number of physicians, what kind of docs are we training? Mercer's a primary care medical school. Most of our students now are going into other specialties. They have a $200,000 debt when they leave. They're not thinking, I think I'll be a family doc somewhere and make whatever it is they make, when I can go over there and make 5 or 10 times that doing something else. You know where they're going. So their incentive right now is to pay off their school debts, make a good living. You get that with Mercer, just you do graduating from anywhere else. So we haven't found a way yet to, and here's my personal dream, it doesn't cost a dime to go to medical school. You go to medical school and it's free. But you have 3 years of public service. You go into primary care during those years. There's a very limited number of specialists available. That's a cost containment measure because we don't need all the subspecialists we have. That's one of the primary reasons we have the highest cost of care, all the subspecialists. And don't improve outcomes. They actually decrease the quality of outcomes because of the adverse events. Are we going to shift to that system? No, no time soon. But I think actually the cost of that, of making medical education free, here's one of the big, and Carol probably is aware of this, what's one of the biggest healthcare challenges we're facing over the next 20 years? Us old folks. We're going to be out there. What are we not really training enough of? Geriatric physicians. We have a lot of geriatric physicians, but not enough geriatric specialists.
Dr. Hill myself.
Yeah. That's another role for government in this, is to say, well, let's look at both the number of physicians and, equally important, who are we training? What are we training them to go into?
And that's a good point because our system is so disjointed right now. I know from a counseling standpoint, when I come in and you've got a patient who has 5 doctors and there's nobody driving that ship. But the family practice doctor is trying his best to run his practice outside of the hospital, and he's making less money than all of these other doctors. And so you've got him who really, these other ones who think that I guess they think they're in charge, but they're only in charge of one organ. And so they come in and say, yeah, your lungs look great today, but your kidneys are failed, the heart's not working, but they don't care about that. They're only looking at the lungs because they're the lung doctor.
Everybody likes to say bad things about managed care because it kind of affects our choice. But if there's one good thing about managed care and having to go through a primary care physician, is it keeps the specialists from over-specializing and letting you get like sepsis, or, as she said, you got somebody who's got 3 things wrong with him. You got a dermatologist, a heart doctor, and a kidney. And You know, nobody's.
You would think that that person that has that much responsibility would be the highest paid doctor, but they're not. They're the low end.
I have a quick question. Mr. Faulk, you spoke about preventative medicine and removing some of the, or changing the way some of the smaller hospitals operate. It would seem to me that if you have more access to healthcare, you would have more of a preventative measure in place instead of having so many people coming from rural areas to a level 1 trauma center. How does that work now compared to what you all would like to see it?
I think now a lot of people go to Peach County. A lot of people from Crawford County doesn't have a hospital. They are not getting care. They just don't get care, and when something bad happens, then they come in. You know, they may get something, they may not. If they are getting preventive care, if they are having a wellness visit every other year, every 5 years, you know, for whatever, anything would be better than I think what we've got now. There's a chance of picking it up. The one thing that's going to do is going to drive up the demand for physicians or some other mid-level practitioners that could work. And, you know, so that access is going to drive up demand at that level. And I'll tell you, they're going, for a while, they're going to find more stuff that basically now people just have until they fall over and die. It's going to be more expensive as they pick up some things along the way. Long term, I think it'll level itself out. But I think it's going to be one of the very difficult things that we've got to work our way through. And I'm a little concerned about the economic impact of that, because I think that you open up the access, if you can find the physicians, and I do think that's a huge issue.
And he's exactly right. Areas that have a higher physician per capita ratio have fewer preventative services. We tend to start migrating towards practices that are more procedure-oriented, and they neglect those conversational, end-of-life decision, preventative practices. And hate to be cynical, but again, I think it's largely driven by the need to augment their incomes.
That's right, because insurance doesn't cover the
A lot of those
annual
other
physical
things. That's right. Good question.
Yeah, I have a question. When we were talking about the insurance and covering it, what about the transitions from the people who, okay, hold on. Okay, you know, the juvenile diabetic rate has gone up. So after they graduate college, they're dropped from their parents' insurance. As a type 2, you can have insurance, but not as a type 1 insulin dependent. But that goes against with the incentive rate that, you know, if you can lose weight, exercise, eat properly, that can go down, the risk goes down. But there's nothing you can do for a type 1. So is there going to be anything in the insurance?
You know, that's where I think community rating has got to come in, because, you know, if you've got somebody at 22 or whatever that it's like all the other 22-year-olds, except they've got diabetes, that you know, for them to be so economically disadvantaged of trying to get some health care to deal with that versus their counterpart right there, it is just going to be a huge case of haves and have-nots. And that's where I think the community rating really does have to come in, and that's where I think everybody needs to play in the system.
And I think that in the new bill, they prohibit insurance companies from using pre-existing clauses. So at least you'd have access. I didn't say anything about the cost, but at least there would be access. They can't just barter.
And under that current House bill, you're under your parents' insurance until you're 27.
Yeah.
So there's no reason to get out of school.
Professor Sanders.
You know, listening to the experts, it sounds like the fix is complicated, but if you listen to conservative talk radio, or Fox News commentators, or letters to the editor written to the Macon Telegraph, it sounds like if you just stop giving this care to illegal aliens, we wouldn't have a problem. That's the root cause of all of this.
As they go again.
And I'm telling you, law students in discussions, I mean, some people, you know, really buy into this notion that it's got to be tied to the immigration policy, that that's where the problem lies. As people who actually work in the field, how do you deal with angry people? This kind of anger that comes up when you discuss reform that isn't related to any of the things you're talking about, But it's these people coming across the border from Mexico or something.
Yeah, I was asked to do a town hall meeting in my church. I'm hoping that, maybe these church people aren't going to start throwing things. So that, the question of illegal aliens came up. They do have access now. Again, they come right into the same emergency room as all the other uninsureds. Now, should you give them full ticket? I don't know. The one thing, I do read the letters to the editor, and you never know what you're going to find. The guy who wrote one yesterday actually had a pretty good suggestion about the 1 cent national sales tax that would pay for all of this stuff. I don't know if it would or not, but in his vision it would. And then you tax the people who make and spend more. The rich, they spend more stuff, so they pay a lot more. You tax that illegal who goes to the Kroger and buys his groceries. He's paying his little share for whatever he gets. Whether he gets the full meal deal, I don't know. But it's that is one that I hear a lot that is not a substantial part of the problem. There's millions that fit in that category, so I won't write it off. But in terms of, if you fix that problem, we've still got a huge national problem with health.
There is a huge national problem, even if you take out that part. But again, we're not in Brownsville, Texas, or Phoenix, so it's relative to different geographic areas. But is it the only? No, And the way I deal with people who get angry on this is I just don't talk to them. How many of us have not had a good discussion about that? This because you know that the person is getting their news from either Fox News or MSNBC or Frank Gadbo in the Macon Telegraph.
Yeah.
So the thing to do
Well,
is...
looking at it from a human perspective, I've had several people who, to me, when somebody is under our care, I don't know who they are, where they are, whether they're legal, illegal, or not. That's a human being laying in the bed in front of you that, what are you going to look at them and say, I'm sorry, but
you all talked at the beginning like health care is a basic human right.
Yeah.
And having grown up in the 60s with pictures of Eleanor Roosevelt around my house, I agree. Now, there are law students here, intelligent law students who say, what makes you say that health care is a human right? Where do you find that in the Constitution?
Let me just tell you, I'm a Republican. My dad was a member of the John Birch Society for many years. He's still alive. I have to talk to him. I can't just ignore him. And he's a sweet guy. I'm going to go see him next week when I'm out in California. And I listen to Neil and Sean and Rush and Mike and guys like that. And my answer to this is, why do we make them all so illegal? I mean, I grew up in California, and a lot of these guys and the women working in the fields and doing other work, why do we have to make them so illegal and lose the tax base and lose our ability to pay for some of this care? That's the part that I'd be looking at.
Yeah, you got to fix that. I mean, to me, weren't we all illegal at one time in America?
Not me.
Everybody that came over here was...
Lots of people came over legally.
Just, Mike, real quick, the answer to the law students, if you want to play that game, is we're in a country of negative rights. Just get the hell out of my way. Give me the opportunity to pursue my health care, not give me health care.
First, Professor Jones.
Just one quick comment following up on Dick's point. Everybody's focused on healthcare right now in Congress or something, but on the agenda is immigration reform, and to the extent that there will be crafted into any ultimate reform some kind of legalization track, to that extent, this issue should cure itself. I would surmise, I haven't seen the text of the healthcare provision, but if you move the illegal aliens from the illegal side of the line to the legal side of the line, do they not then become eligible for whatever healthcare benefits or in healthcare benefits?
Got a couple questions over here.
I guess mine comes from, what exactly is the role of the AMA in qualifications for becoming a doctor? Because I understand, I have no interest in going to medical school. But I know people who are there, and it's not exactly the funnest experience. It's extremely difficult to become a doctor. I understand why they want to make a lot of money. Is there any way that we can change the qualifications for someone to be a healthcare provider that doesn't take such an arduous task to actually get that license?
Well, some of it's just going to be arduous because of the work. It's interesting, if you look at the level of moral reasoning among medical students, maybe it's true for law students too, I don't know, but in medical students it actually starts out quite high. A lot of idealism, and by the time that after 4 years they become cynical enough And they're starting to think about those loans are coming due sooner or later. I've seen these guys. Our role models are out there. And this fits in with our notion of the hidden curriculum in professionalism. That too often what we teach and what we do are two different things. And one of the things that we're interested in the medical school, and I know that you have a big interest in this in the law school too, is looking at professionalism and how you teach it informally as well as formally. So that's one of the things we need to do to help people not become so cynical. I still think we need to give people enough subsidy that they aren't driven to these decisions economically. I was very fortunate. We had a war going on, so I went in the Army. I became an Army doctor, and I liked being an Army doctor, and they paid for everything. So my path was really pretty easy. So I was a general medical officer, and I didn't have to worry. They paid all my books and tuition. I had a good time. These days, that's not such an attractive option. And these days, and the public health service is not the option that used to be either. But I think we need to find another way of both building up our informal, our hidden professionalism curriculum so people can stay focused on those things you went to law school and medical school for in the first place, and not be driven away from those ideals by this need to pay off your debts.
Here's a question for you. How come you don't want to be a nurse practitioner or a PA?
I want to be an attorney. So.
I know. I mean, well, you know what I'm saying.
One more question. We're going to have one more question, but before that I wanted to tell you that the coverage of this roundtable is scheduled for tonight at 7 p.m. on WMAZ, which is our local CBS affiliate. Apparently they're going to cover this to some extent. Question?
What is this kind of a two-part question? But what do y'all view, I guess, is like the most informed or effective impetus or driving force? Like what group, I suppose, should be in charge of kind of making these changes? Do you feel like the federal government is better versus the states? And what is the role for us as young lawyers in that?
Well, we've seen some of the problems if just state governments are in charge, say, of insurance. I think federal government has a leading role. Because Medicare, if you look at, people say, oh, we don't want big government involved. Well, almost 50% of our healthcare system is big government. Between Medicare, Medicaid, VA, federal insurance plans, military, 50% is already big government. They're by far the biggest negotiators when it comes to drugs, inpatient rates, reimbursement in general. They have to have the largest role in this. But we don't want to ignore local situations because different parts of the country face their own challenges, their own demographics, for example. And so we need to have some local control over the situation too. So it has to be a balance between the two. I don't know if I can say anything more intelligent than that about how to achieve that balance. I think it's a continuing dialogue.
I'm a little, and I'm sort of having watched the food fight in Washington for the last 90 days, trying to figure out, where is anything intelligent going to come out of this process? I'm struggling a bit. Because there has been a lot of dialogue before the election, before we knew whether it was going to be a D or R sitting in the seat, by groups, the AARP and the American Hospital Association and AMA, for about 3 years, and I was a peripheral part of some of that. And there's a good, I mentioned in a little letter, there's a good framework, I think, for some rational healthcare reform. After watching the food fight, I thought somebody would pick up the ball and run with it, but apparently that's not the game of the day. So it's my thought is they probably ought to send. You could probably get 30 people, 30 knowledgeable people nationwide, send them off for 6 months away from CNN and Fox News and away from everything else, and bring back a workable solution.
Didn't we do that a few years ago?
This is sort of like BRAC. I mean, it could be like BRAC, where the Congress could either vote it up or vote it down, but they could screw around with it.
Didn't we do that in '94?
No, well, that was after we thought that was a way to do it. We didn't know we needed to change hospitals. In '94, they thought the current system might last a while. Hospitals know now this system, if we don't reform it, is going to die of its own weight. And I think there's an urgency that would make it more acceptable. I think if it came back with a vote up or vote down, we might have a more rational system, but I don't see that happening because they lose their control.
Well, I think they made a conscious decision not to do that. Because I agree with that sort of you might say an expert-driven consensus. Exactly. But the problem is that they did that in '94, and it came back and Congress said pretty much, who owns this?
Yeah.
We had nothing to do with this,
Yeah.
and you know what happened.
It's got to be DSNRs again.
Listen, I want to thank our panelists for joining us, and I'm sure you all do. Thank you for being with us today and your questions and your attention. And we'll stay afterwards. We're going to have a reception over at the Woodruff House. Please join us. And also, I'm sure they'll be happy to sit and answer your questions informally afterwards. So thank you very much.